All right, good evening, everyone, and welcome to our first Bariatric Happy Hour session for the 2024-25 year. I am Faiz Shariff, a metabolic and bariatric surgeon from Pennsylvania, and I'm thrilled to be your new host. Joining me today is Dr. Juyeon Park, a newly minted fellow metabolic and bariatric surgeon. And for those of you who are joining us for the first time, these are webinars that are held on the fourth Thursday of each month. And during these sessions, what we aim to do is to review some seminal papers that have significantly influenced our field and alternate these with discussions on technical aspects of metabolic surgery. And in addition to that, I just want to give us a few shout outs before we start the session. One of them is that the Bariatric Surgical Training Committee actually hosts monthly fellows hours. Now, these are going to be covering key topics from your core curriculum. And these sessions actually counts towards your didactic requirements that you need to obtain your ASMBS fellowship completion certificate. Besides this, the application for the START program is now open. So START it stands for ASMBS Surgical Technique and Advanced Robotic Training Program. It's a unique year-long educational program focused on bariatric robotics training. It consists of a series of didactics from the leaders in the field, and it culminates into 1 day of hands-on training session. So I highly encourage you to apply for these. Besides that, you have two other things. One is the ASMBS weekend. That's on the November 7th to the 9th. So please join us. And then the ASMB Leadership Academy. This is now a unique career development seminar and workshop for all bariatric and advanced GI MIS fellows. And that will be held just prior to the weekend. That's on November 6th to the 7th. So weekend is 7th to the 9th, and the Leadership Academy is from the 6th to the 7th. Having said that, let's come back to our topic today. Tonight, we are discussing the updated recommendations for indications for metabolic and bariatric surgery. It's an honor to introduce our guest speaker, Dr. Dan Eisenberg. Dr. Eisenberg is a professor of surgery at Stanford University, the medical director of bariatric and minimally invasive surgery. He's also a fellowship director for Advanced GI MIS Fellowship at Stanford. He earned his MD at Washington University before completing his surgical residency and fellowship in MIS at Yale. And at ASMBS, and for those who have worked with ASMBS, he has worked tirelessly to advancing the obesity care. He has chaired the Clinical Issues Committee. This is the committee that kind of puts out your position statements, does the literature search, and has maybe led the most important project, the National Guidelines Update, which we will be discussing today. Besides this, he has co-authored many landmark papers in our field. It's a privilege to have you here, and thank you for joining us today. I know you have a busy schedule, and I'm sure our fellows would love learning from you. We also have Kristin, Bremer, Juyeon, Dr. Park. Do you want to introduce her?
Yeah, so this is Kristin Bremer. She is our fellow from Albany Medical Center. She just finished her residency over at Creighton University School of Medicine. And before that, she was at University of Iowa for her MD. She is going to be introducing the paper to us with a little presentation. This is the basic format that we have for all of our bariatric happy hours. The fellow will do a little quick presentation. It's very informal, so anyone at any point is free to ask any questions. Just put it into our little Q&A chat box, or just raise your hand and we'll message you. And any of our panelists who are on can also answer any questions at any time. And for any of the fellows who are on, if you would like to be a part of this in the future, please just send us a message and we will send you the link to sign up to be a presenter. So Kristin, if you can take it away.
Before Kristin starts, I just want to give a shout out to Dr. Dan and Dr. Juyeon Lloyd. Dr. Dan is just a past chair of this bariatric training committee. Thank you for joining us. And as if you have been to the Bariatric Happy Hours, Dr. Juyeon was the previous host here. So thank you guys for joining. And Dr. Bremer, you want to take over?
Will do. I'll share my screen. Just give me one moment. So I'm going to be talking about the paper, which was the ASMBS and IFSO indications for metabolic and bariatric surgery. And for those that aren't aware, IFSO is kind of like the international version of the ASMBS. It stands for International Federation for the Surgery of Obesity and Metabolic Disorders. And they put out new guidelines in 2022. And these guidelines had been a replacement for the prior guidelines, which had been put out in 1991. So I guess just to start, why were the new guidelines made? Well, the old ones were 30 years old. They were, just for perspective, published back when vertical banded gastroplasties and open Roux-en-Y's were the most common procedures. And you can imagine how much the field has changed since then. Since then, a huge body of literature has increased our understanding of obesity, metabolic disease, and bariatric surgery. There has been many long-term studies that have proven that bariatric surgery is effective and durable, and that its comorbidities have good outcomes that are superior to non-operative treatments. And then the safety of bariatric surgery has also been demonstrated to be excellent, with a mortality between 0.03 and 0.2%. Most of you are probably most familiar with the old guidelines. Many insurance companies still use these guidelines to allow patients to have bariatric surgery, and then they're still in a lot of our older textbooks as well. And the older guidelines were that bariatric surgery should be offered to anyone whose BMI exceeds 40, or folks with a BMI greater than 35 plus obesity-related comorbidities. And these include hypertension, diabetes, hyperlipidemia, all these other things included here that you would expect as being related to obesity. The new guidelines, this is just a summary, and we'll go into a bit more detail. MBS just stands for Metabolic and Bariatric Surgery. So bariatric surgery is recommended for patients with a BMI greater than 35, regardless of the presence, absence, or severity of comorbidities. Bariatric surgeon should be considered for patients with a BMI from 30 to 35 if they have metabolic disease. And then it should be considered in patients with a BMI of 30 to 35 who have not achieved sustainable or durable weight loss or comorbidity improvement using non-surgical methods. It also discusses BMI thresholds being adjusted for the Asian population so that a BMI greater than 25 is suggestive of clinical obesity, and also suggests offering bariatric surgery to patients with a BMI over 27.5 in the Asian population. It discusses bariatric surgery for children and adolescents with a BMI which is greater than 120% of the 95th percentile and major comorbidities, or greater than 140th percentile, and even without comorbidities. There's no upper age limit for bariatric surgery, and it also discusses that severe obesity is a chronic disease, so there are patients that might require other long-term management, including revisional surgery or other adjuvant therapies. So just talking in more detail about class 1 obesity, this is folks with BMI of 30 to 35. This is one of the biggest changes, given that typically with the old guidelines, patients had to have a BMI of over 35 to qualify. And the reason for this change is that prospective and large retrospective studies have supported consideration for bariatric surgeries in this patient class, especially those with metabolic disease, just given the increased survival and beneficial outcomes for folks with diabetes, as well as hypertension, dyslipidemia, obstructive sleep apnea, etc. Slide. For patients greater than BMI of 35, as you may recall, historically, patients that had a BMI of 35 to 40 would require another comorbidity, but these new guidelines state that another comorbidity should not be required to consider bariatric surgery in this population. And one thing that I wanted to go into more detail for is the recommendation with regards to the Asian population. One study that I found very interesting is the one I show here on the right, and it talked about the risk of having type 2 diabetes based on BMI, if you compare it to the risk of a white person with a BMI of 30. And as you can see, you know, you can see in the lines here, South Asian, Arab, Chinese, and Black patients have a, equal risk at a much lesser BMI. And that's one of the reasons for this recommendation change among the Asian population. It's the fact that their comorbidities are much higher at this lower BMI, and bariatric surgery could help resolve these comorbidities for them. There was discussion of extremes of age. There were multiple studies discussed that showed good outcomes for patients, even older patients that had surgeries, and then younger patients that had surgeries as well, which is my next slide here. One of these studies quoted, patients as young as 5 years old having surgery with beneficial outcomes, and they gave some good guidelines for cutoffs for bariatric surgery according to weight for children. It talked about bariatric surgery as a bridge for other treatment, such as, patients that need to undergo joint arthroplasty, abdominal wall hernia repair, or organ transplantation. And then there's always a question of, is there like an upper BMI cutoff where it becomes too unsafe to operate on these patients? And basically there's no consensus on best type of procedure for these patients, but there has been plenty of data showing BMI, even for those with a BMI of over 70, as being safe for undergoing bariatric surgery. And if anything, these patients probably have, good benefits from undergoing surgery, given that they have so much risk from being overweight. And then discussion of patient evaluation. I think this kind of stands true that patients should be evaluated by a multidisciplinary team prior to surgery, just for optimization and patient selection. And time should be spent assessing the stressors that may affect the patient's long-term outcomes, things such as financial, housing, and food insecurity. And then there was some verbiage in there that there's no data to support the practice of insurance-mediated preoperative weight loss. A quote from the paper is, "This practice is understood to be discriminatory, arbitrary, and scientifically unfounded, contributing to patient attrition, unnecessary delay of life-saving treatment, and progression to life-threatening comorbid conditions." So, and then revisional surgery, just some discussion that it is safe, but it may be associated with slightly increased hospital length of stay and complications. Another quote from the paper: "Nonetheless, revisional bariatric surgery is effective in achieving additional weight loss and comorbidity reduction after primary operation in selected patients with acceptable complication rates and low mortality rates." And then plenty of other benefits of bariatric surgery, such as cirrhosis, heart failure, cancer, and overall mortality. I thought this was one of the most interesting statistics, that when a patient undergoes bariatric surgery, they have a median life expectancy increase of, on average, 6.1 years. And for those with baseline diabetes, it's actually 9.3 years. I feel like that is a very strong selling point, just for how beneficial these procedures are for patients. So just as a conclusion, I just, again, summarize the guidelines. If people wanted to review that during our discussion, it's the same as my prior slide, but that's kind of a summary of all the new guidelines for our discussion. Does anyone have any questions at all?
I think we'll ask Dr. Eisenberg to give us a little bit brief overview about how this came about, and a brief summary of exactly what you said so far.
Yeah, sure. This was really nicely presented. And I thought that, I actually thought it would be instructive to give a little context as to how and why we got to this point of bringing these updates. So to illustrate the point, I have a couple slides. So can I share my screen?
Absolutely.
I'll try to do it correctly.
That works.
Okay, what can you see?
We see method study design.
Is this better like that?
Yeah, that's
okay.
Perfect. Thank you.
Yeah, so just to give a little context, this is an example of a paper fairly recently published in Obesity Surgery. It's not to pick on these specific authors, but this is kind of an example of a typical publication in the field that we read all the time. Here are the methods, and it suggests that all patients in their inclusion criteria, all the patients met the U.S. National Institutes of Health criteria for metabolic and bariatric surgery. And here they give reference number 30. And this reference number 30 is the 1991 NIH Consensus Development Statement. So we are still constantly in our research and in our criteria for doing surgery are referencing something from 1991. Now, a little bit about this consensus statement. It was actually born out of a 2.5-day meeting. It was a 2-day open discussion in which 20 speakers participated. And then it was a half day of closed deliberation by a selected 14-member panel. And it should be noted that this panel consisted of 2 surgeons. And that produced the 1991 consensus statement. That was it.
Wow. So just 2 surgeons in a panel of 14.
Correct. And this was the environment, as Dr. Bremer suggested back in 1991. They were evaluating bariatric surgery at a time when they were actually, this is a figure from this statement in which they showed the bariatric procedures that they were considering, the open VBG, which hopefully none of you have seen before, and the open Roux-Y gastric bypass. In 91, they were acknowledging the fact that there are no quality standards. There is high morbidity for these procedures. Small case series, very few randomized trials. They were working with short-term follow-up, and they were referring to it as weight loss surgery, not like we are considering it today to be metabolic and bariatric surgery. And there were very few high volume centers compared to what we're used to today. A little more context, in 1991, Gorbachev resigned and the Soviet Union ceased to exist. And this actually happened before Justin Bieber was even born. So a little more context. And it's important because a lot of what we consider bariatric surgery today is based on a lot of studies that evolved since then, in the introduction of laparoscopic surgery, and also more recently bariatric surgery in the context of our practice. A finer point is if you think about our knowledge base, on the left here, you can see our understanding of lipid metabolism is much more complex than what it was in 1991. And on the right, you can see in about 5 or 6 years ago, there was a ranking of the top 100 papers cited on different topics, and this was the topic of obesity. So the top 100 papers cited, you can see them here, based on publication year. And the vast majority were published after the NIH consensus statement. So really, the NIH consensus statement no longer reflected what we do and what we know. Because the current state, we're talking about, again, laparoscopic and robotic surgery. We're talking about different operations that we're performing. We acknowledge low morbidity of the operations we do. We have high quality standards and different quality projects involving bariatric surgery on a national level. Randomized trials, large case series, cohort studies. This is what we expect of our publications now. We consider it metabolic surgery. Medium and long-term follow-up is what we're used to. And There are worldwide data from many high volume centers. And we also have to consider what are goals of guidelines. They are here to serve our patients. We need to demonstrate that we deliver the best evidence-based care. It's important also for our providers that seek to understand the disease process and establish best practices. For our surgical society, it is critically important that the guidelines under which we operate actually reflect our practice. Otherwise, they're pretty meaningless.
True.
And for the general public, they look to our guidelines for education about disease processes and treatment options. So in that context, IFSO and ASMBS, like Dr. Bremer mentioned, they sought to bridge the gap in available evidence because the time has come to evaluate the objective evidence for bariatric surgery and reassess the indications for surgery. So what we did is we kind of narrowed down to these topics that Dr. Bremer nicely presented about what we need to look into to address this gap. And a 24-member task force from both societies representing 9 different countries kind of underwent this process, just so you know a little bit about the process behind what produced the publication. Did an extensive literature review looking at those topics that we sought to bridge the gap in the 1991 statement and the current state. Specifically giving high kind of emphasis for randomized trials, as well as larger cohort studies, focusing on those with mid and long-term follow-up and those published more recently. So focusing on those published in the last 10, 15 years. The draft that was produced was then circulated to ASMBS and IFSO independently, seeking comment and revision. And that kind of repeated a cycle to finally produce the update that was reviewed tonight. Just as a final note, Dr. Brolin, who I haven't met in person, but he was one of the surgeons who were in the open discussion panel in the 1991 NIH conference. After this was published, he found me and wrote me a quick note saying that the updated indications recall all of our struggles to obtain recognition that bariatric surgery is a safe and effective treatment alternative. We've come a long way. And I think we've come a long way indeed. And I think this is something that we should establish as kind of a reiterative process. So this is a good update for today, but we should keep it in mind that this is something that we should actively revisit and make sure it reflects our practice and our knowledge. And just as a shutout, in the next few weeks, look out for an evaluation of the scientific evidence behind the update that should come out. So thanks. That's just my 2 cents on kind of how we got here.
Thank you. I mean, thank you from all the bariatric surgeons. We kind of knew what was, the benefits of the surgery. And like you just said, following something that was 30 years ago, I guess I was in elementary school at that point, So my question is, why did it take us 30 years? And why was the first guidelines by NIH and not from, help me understand, ASMBS was in existence back then. So how did it be, why was NIH the ones that were putting out the guidelines and not really having bariatric surgeons back then? And now why has it taken us so long to come up with these guidelines?
Yeah, that's a quick question, a great question. And I'm going to, I'll use my answer to kind of establish my position that the NIH guidelines were actually really good, and they served us really well for a long time. They importantly established surgery as a effective tool that needs to be considered in treating a very select population of patients. And that wasn't always obvious. I mean, we kind of take it for granted now, but that was not always obvious. And I think back in 1991, that was an important step. And it was really important that actually it came out of the NIH, and that it was a panel of some surgeons, but a lot of non-surgeons, because that really gave it a lot of emphasis, and it gave it what needed back then to be non-surgical gravitas, that surgery is a treatment option. So I do want to highlight that. Now we kind of are trying to push it to the corner of the room, but it really served us a valuable service for quite a while. It took 30 years to tackle it directly, but it would be unfair to suggest that there weren't other important consensus statements looking at the impact of bariatric surgery on diabetes along the years that really brought us to this time. So while the NIH is something that's quoted as our standard, over the last several decades, there were seminal papers along the way that kind of chipped away at our understanding of the importance of bariatric surgery to our patients and its impact on obesity in general.
I guess, well, we as neurosurgeons, you're right, we don't understand the landscape back then, and now we kind of take it for granted, like, oh my God, there is evidence there. But if you look at the evidence that, like you said, it has come recently. The other questions, and I can see Scott has put in a question. How do we move from here, getting these guidelines to be adopted by insurance? And I know that's a $100 question, $1 million question here. But what do you think? How do we move forward with that? And I can add to that what we have done in Pennsylvania after your answer.
Yeah, no, I'd be very curious to hear what you and the other panelists have to say. We anticipated this to be kind of the potential issue, that we didn't want it to have be a statement with no teeth, and the teeth really is this improving access for our patients. So we actually talked about it quite a bit, and we tried to work through the press when it just came out to really put pressure on insurance carriers from the patients. So that was the main approach. There's definitely going to be, and probably is, some pushback, but there are kind of pockets in the country where it's starting to make an impact among the insurance carriers as well. So I'd be very curious to hear what you have to say. And the other thing is to continue publishing the data. I think that's our biggest friend. And I hope that the publication coming out showing the scientific evidence behind all the updated points that Dr. Bremer mentioned will be another step towards that pressure of what guidelines can do for educating the society.
So from my perspective, as soon as these guidelines come, what we did at in my hospital or health system, we have our own insurance. And we used those guidelines, and we went up to and met the director there and said, hey, listen, these are the guidelines from the International Society. Had to have a couple meetings, but we got it approved. So everyone who is at WellSpan now follows these guidelines here. And in competition, what happened was UPMC, which is a competitor, have adopted those. Now, I don't know, I think they might have come up earlier than us, or it might have been going on in conjunction. But I would say a lot of more insurance companies are recognizing this. Now, you still have some majority that are still like, being difficult, but I feel like it's becoming more mainstream. Now, maybe because these new medications have come out and they're expensive, now surgery seems like a better, more reliable option, and that's what the data actually has shown. But I feel like insurance companies are listening to us, and thanks to these guidelines, I really do think having a guidelines put so well together by ASMBS and IFSO really helps our cause. It makes our job easier to say, hey, listen, these are well-studied guidelines here. And, a lot of insurances are approving that. So to push the ball forward, it is. But I guess it takes all of us to do that. It's not just one person or one society. It's all of us coming together to do this. So anyone else wants to add? Dr. Adrian Dan, Julie Lloyd, what have you guys seen in Cleveland and elsewhere? Dr. Park?
I'm just unmuting myself here. Faiz, thank you. Dr. Eisenberg did a wonderful job of summarizing not only the reasons that we got here, but also as a first author on this very important manuscript. And Dan, you ought to be congratulated. And I know I've done that in person. I hope that you saved that note from that surgeon from the 1991 consensus, because that's a piece of history. But gosh, if you look even back at the 1978, the first consensus, we were looking at outrageous morbidity and mortality rates, and the procedures that were listed in those first guidelines included jaw wiring. That was mentioned, and obviously things we don't do anymore today, like GI bypasses and vertical banded gastroplasties and things like that. So everything in metabolic and bariatric surgery, including the name, has changed. And most importantly, I think one of the things that really had to be readdressed is the fact that by the time these guidelines came out, we had no fewer than 12 randomized controlled studies proving the benefits of metabolic surgery and superiority compared to the best medical therapy available at that time. So we needed something badly to underscore the need to apply this therapy for patients with diabetes that had a BMI of less than 35. Everything had changed, as Dan has mentioned, including the morbidity, the mortality rates, the application of this therapy for so many conditions that are associated with obesity. And yeah, we have come a long way since those early guidelines. And the NIH, they just frankly don't care anymore to be in the business of creating guidelines. And that's why it took 30 years, and it's up to our societies to pick up the I don't want to say the burden, but the task of developing new guidelines.
That makes sense. Right.
Yeah, I would say my experience has actually been very similar to probably Adrian's, not as much Faiz. In Houston, we've been very slow to change. And I think it's difficult sometimes, because from my perspective, the disease of obesity is the only one where we actually have to get permission from the insurance before we can treat the patients. And I find that talking with the medical directors, talking with the people who are trying to get patients through to surgery is not really as effective in terms of getting the insurance companies on board. I agree. I think the societies will have a huge impact I think, having more data out there showing the benefits of bariatric surgery over not doing surgery will also help. These things are going to take time, I would imagine, within the next couple of years, especially as we get more obesity medications. The stigma around obesity and its treatment will probably go away, and we'll have an easier time getting patients through to surgery.
But it definitely helps having a guidelines that are so well put together. So thank you again for doing that, because you kind of have made it easier for us to present this. Like if I have a conversation with my medical colleagues, it's amazing how we think makes such a big, huge impact. We see our patients, we see the good, the bad, and the ugly, right? But when you talk to your medical colleagues, they don't necessarily see that. When you talk to your PCPs, they don't necessarily see that. So having a guidelines, it kind of really helps. And especially now I'm looking forward to the scientific data that comes out from here. So, we can disseminate this to all our PCPs. It's not just for the insurance company, but it's also for our colleagues in other fields to understand that. So that I think is also what this guidelines does when it's like so nicely put together, because a lot of patient, specialties don't believe that a BMI of 35 without comorbidities need to be operated on. But we know what's going to happen, what the natural progression of this disease is. So when you say this has been studied, it makes it easier for them to kind of, understand that.
Yeah, I think that's a good point, because it's always surprising to me, and shame on me for that colleagues I work with on a regular basis, when you dig a little deeper, they don't really believe in the benefits of bariatric surgery, and will really stonewall a referral for a patient who is really seeking more help. It always catches me by surprise. So yeah, I am hopeful that even in that kind of communication and in that flow of clinical care, that this will have an impact. I'm curious, you mentioned in your hospital that they accepted it. Did they accept it wholesale, or did they kind of pick it apart?
They did not. They accepted it wholesale.
That's
And
great.
another difference it made is, just to give you, we are like the largest hospital system between Baltimore and Lancaster. And what we noticed was that our bariatric volume was going down last year. And if you look at our medical weight management volume, that was going exponentially high. So what we did was we used these guidelines. We spoke to our population health, and we used these guidelines to say any patient greater than BMI of 35 is going to see a surgeon as opposed to a medical doctor, because no matter what anyone has to say, I don't think anyone can explain all the treatment options for obesity better than a surgeon can.
Right.
Say I'm biased, maybe I am, but I just think, it's hard for them to understand. So instead of having a BMI of greater than 40, we reduced it to 35 solely based on these guidelines. So I think that, again, made a huge impact. So, our medical director was very receptive to this idea. It caught me by surprise. Now,
That's great.
having said that, I don't know if there was other capital group costs had accepted that. So did that make a difference? I'm not sure, but it wasn't a challenge for us here.
That's fantastic. I suspect that's not the common scenario for most people, but it's great to hear, especially when it's impacting so many patients.
It is. It's dramatically, because our wait times for medical weight management was 6 months. Now they can see one of us, and the conversion rate. Now I don't have long-term data to say if all those patients who came under the medical tree are actually getting surgeries. We just started doing this since Jan. So I do see my volume has increased. Like I said, because when you explain to them what obesity is, it's a disease and how it impacts you, and it's not just a UTI where you give one treatment and then you're done. It really does make a difference, and our conversion rates have been satisfactory so far.
That's great.
We have another question from the audience. Dr. Pratt was asking about how often do we think that these updates need to happen? Every 5 years, every 10 years, every
Hi,
30?
Dr. Pratt. So I'll give I'll start by saying that I don't know. I think a lot of the timing will be dictated by new information, new data, new big studies, and I think we're now kind of in a place in our field where bigger, well-designed, scientifically robust studies are much more commonplace in bariatric surgery. So I think what we learn and what we uncover will dictate. It's all a question of when the updates become dissonant and they don't really correspond to what we kind of empirically know. But I'm curious to hear what people think, whether there should be a specific time period where these kinds of things need to be revisited. I know in the clinical issues committee, we try to have a cycle in which statements and guidelines are looked at and maybe warrant a literature re-review, if nothing else, just for our members to be reassured that what they're doing is still relevant. But I don't know if Dr. Pratt is able to unmute. Like, what did you have in mind? What do you think?
Can they do that, Cody? Okay, there.
It can be added.
Yeah,
Yeah,
I just
she
gave
did.
them the ability if they would
Wow,
like.
that's kind of cool.
Uh-huh.
I guess I should turn on my video too, but I don't know how. Anyway,
I should
yeah,
just
so
note to Dr. Pratt, co-author in the update, and a big contributor on the adolescent surgery portion.
so I don't know what the answer is, but I think we shouldn't wait more than 10 years. I agree that we need sort of new data and new information, but if we can simply put out another paper in 10 years that says, you know, this is the updated data, it's even more supportive of these guidelines, even if we don't change the guidelines. Until we get all of the insurance companies never denying surgery, we
Oh,
need to
that would
keep putting
be,
out guidelines.
oh my God, that would be a dream.
Yeah, I agree. I mean, and I think at the pace that we're going now, if you look at the publications that are being published in JAMA and JAMA Surgery and New England Journal of Medicine, I mean, bariatric surgery is occupying a good space in the medical literature. So I don't think 10 years is going to be too long to wait. I think we're going to have robust data long before then.
Yeah, I agree. And certainly in pediatrics, we're still fighting. I get a denial every week. I got one today for Monday's case. I had one last month for my case, and that case I added on to the schedule next week when it finally got approved. But denials are not good for patients. They're not
No,
good for
then,
them. Psychologically, physically, there is no reason to delay surgery.
Yeah, agreed.
thank you. There's another question, Dr. Park.
Yes, I'm so sorry if I say your last name wrong, Dr. Al-Mualim. They had a question. Do you expect that implementing a more comprehensive guideline to guide healthcare providers to choose appropriate approach for patients with obesity, so with like surgery, endoscopic therapies, medical therapy, etc., in like the same way as with patients with cancer? You think that's like a possibility for future guidelines?
maybe. I think we're farther away from this than we hope to be. The role of medical therapy is very new. We don't have a good grasp on the capabilities yet, the risks to the patients, the best way to incorporate it in the overall treatment of what is a chronic disease. So yeah, I think we're definitely in the data collecting stage. I think we're further down the road than we'd like to be in terms of coming up with a overarching kind of algorithm of treatment. But all collected data is definitely welcome. But to highlight the point that obesity is a chronic disease, there is no one treatment that's going to kind of take care of it, and we should, and our patients should definitely embrace multimodality approaches, just like we do for most chronic diseases in medicine.
Okay, I had a question, Dr. Eisenberg. Both these guidelines are from the Surgical Society, both IFSO and ASMBS. Was there any thought given to kind of getting, you know, a medical society that deals with obesity? That's the obesity, I forget what it's called. I know they were part of ASMBS before, but now
The Obesity Society.
the Obesity
Mhm.
Society. Was
Yeah.
there any thought just to add some more leverage to this, saying that we all are coming together here? Or is that something that we can look forward to in future, given the data that's going to come out?
Yeah, I think so. Yes, it was discussed. It was mentioned. I think the goal here was really to focus on the surgical treatment and to really make a robust statement from the surgeons. This is what surgical treatment is. This is what it does to the disease. And this is the understanding of the disease from the perspective of surgery. So I think that became really the focus. I agree. Having other societies, non-surgical societies, be part of the discussion is important. And I forget who it was off the top of my head, but in looking at diabetes and surgery, they successfully did that.
I think Dr. Phil Shower, I remember it was in New York, and they did come out with a consensus statement for those.
Right.
Yeah.
So it's definitely valuable, but this update had a slightly different angle to it, and really to take the surgical focus. But hopefully this will be a springboard in terms of it being a starting point for collaborations in the future. What we didn't want for sure is to have a collaboration that would then necessitate us to take a step back and compromise
Sure.
on what we know. So we wanted kind of the surgical perspective to be out there, and a cohesive surgical voice out there, from which then collaborations can build.
I think that was a very reasonable approach there. Dr. Bremer, do you have any questions now that you've reviewed the paper? Anything that came to your head that you wanted to ask?
I think most of my questions are answered. I guess just, is there anything that we can do as we're moving forward in our careers to help progress this along?
Yeah, so a lot of you will be academically active in publications. Reference it instead of the NIH statement. Make it in the methodology. Make sure that this is what is being referenced, and not we shouldn't be the perpetuators of a 30-plus-year-old reference in our papers. And when you talk to your patients, when you talk to them about benefits and risks of surgery, kind of lean on this. This is going to be important. And think of the next questions that we need to ask to make it a more robust argument. To Dr. Pratt's point, we need to keep pounding the insurance companies that this is something that needs to be covered first, and not bombard the patients and the physicians with questions, and let us have all the data in front of us, so that the proof is on the table, and the pressure is on them. But a nice job presenting the paper. Really nice, succinct, and clear.
And I would add that someday you can write guidelines yourself. It's a labor of love. And thank you, Dr. Eisenberg, for taking the lead on this one.
How long did it exactly take you guys to write this?
So this took just over a year. It took over a year to from the inception of conversation with Dr. Kotari and Dr. Shikora, to kind of putting the teams together, to brainstorming, to do the literature search, to get through the drafts. So it was just over a year. It was a pretty intensive year for sure. But I think everybody involved had an understanding of the importance of what could come out of this. So sometimes you need to kind of find motivation to get things done, but this one there was no need to look for motivation. It was definitely, as Janie said, a labor of love.
As a lead author, have you encountered any negative feedback about these guidelines? Has anyone said, hey, this is not,
Yeah, a little bit. I did. There was one that came up in a editorial to the journal. One that the same thing came up in a conference that I presented at, and one was in a conference that I didn't present at. The people were angry that BMI was actually still being used, which is a fair point.
Yeah.
But I thought the anger was a little bit misdirected, to be honest. It's perhaps a discussion for another day, but BMI certainly is what the standard had been for the NIH consensus statement. Still remains a standard for defining the disease with the WHO, with the CDC, with the NIH, with the insurance carriers. So we can work and will work on finding better definitions for what is clinically significant obesity, but certainly in order to make a relevant discussion, BMI is central to the discussion. So luckily I found a little, but not much pushback to what we were trying to say, but that's one that came up over and over again, is why are you using BMI?
Awesome. Anyone else has any other questions? Okay. I know we have 6 more minutes, so if anyone wants to come up with something other than that, again, in terms of advocacy, have you gotten any feedback as to like exactly like what I said? I've used your paper and gone to people. Is that something that have you noticed? Just others have used this to get some more leverage or some more coverage in terms of insurance, and what else can we do to move this the ball forward?
Yeah, so most recently I got positive feedback from practices in Southern California and in Tennessee that were able to kind of use this document to push their carriers to consider what we should be considering as eligibility criteria. So yeah, it seems to be happening in different pockets, different geographical pockets, and I think that's the way it's going to be until there's a critical mass, and then it'll be much quicker, I think.
Right.
So I'm cautiously optimistic.
So am I. And in your experience, compared to other countries in the world, I'm sure because this is now an internationally known guidelines, do you think America is a little bit behind, or we are much better than other countries in terms of accepting that? Because I know I am from India, and talking to surgeons there, they use this heavily, and they operate on patients with much lower BMI. Now, understandingly, Southeast Asians get a more severe metabolic disease than people out here. So has that been your experience, that these guidelines are more readily accepted elsewhere than in America? Because
Yeah, I really don't know to give a concrete answer. I do have, anecdotal knowledge from talking to some people, but I really don't know beyond that. I recently spoke to, a colleague in France, and it seems to be perhaps a little easier, but still there's some bureaucratic stuff that they have to run into. But yeah, that would be an interesting thing to look into more systematically.
agreed. Anyone else has anything to say?
I don't see any other questions in the comment box unless I missed anything.
No. Thank you, guys. Dr. Eisenberg, I really cannot thank you enough for the work that you've put along with Dr. Prats and everyone else on the paper to move this ball forward. And Dr. Bremer, very nicely done. Thank you for summarizing everything else. We will see you guys next month. Again, it's the fourth Thursday of the month. And just look out, register, and join us again. All right.
Thank you all very much. I really enjoyed the discussion, and thanks again. And thanks, Dr. Bremer. Really great presentation.
See you guys later. Bye.
Bye.